Well, good afternoon, everybody. Actually, all you really need to know about me is I used to do bond deals with Tom Fahey like a million years ago. He taught me everything I know. So if this presentation goes south, you'll know the reason why. So I started the day in Park City, Utah, where they host the Sundance Film Festival. Yeah, had to get up pretty early, go down the mountain, fly here to speak to you today. But the reason I mention it is we've been in the process of producing a video about me that we use for Speakers Bureau, and today is the world premiere. We literally just finished it this week. So I've only seen it once, and it was an earlier version. So I don't know, Shannon, is this going to work? Okay, so this will tell a little bit about me.
Our featured speaker is the CEO of Foresight Health, David Johnson. Dave is known for defining market-based solutions to healthcare reform.
Dave's critical thinking has really helped me in approaching problems within healthcare.
He is extremely cerebral, but yet highly relatable. And I think that's a unique combination.
I met him when he was still a banker. And I think he had really, really great insights into how the bond market influences hospital practices.
Dave is absolutely brilliant.
But he is just so passionate about changing the healthcare system.
Terry, my wife, has actually just overcome a pretty nasty bout with cancer, and I remember at one point that we were in an academic medical center, and they were telling her that she had to wait 2 weeks to get a PET scan. So even somebody like me that understood implicitly the nonsense I was hearing, when it's actually your own family member on the line, you kind of pull back a little bit. What we as a system need to do is not put people like us or any of us in that position where we're choosing between what we know is not a great alternative and something that we think might even be a worse alternative. We're going to be giving people good choices, not mediocre or terrible ones. Coming out of college, the only thing I really wanted to do was go into the Peace Corps. So I ended up being a Peace Corps volunteer in Liberia, West Africa, teaching language arts, so basically English. Came back to the United States, went to Harvard Kennedy School, got a degree in public policy, and discovered, somewhat to my surprise, that I really liked finance and statistics and econometrics. After a tour of duty as a U.S. presidential management intern, I ended up in investment banking, doing healthcare. So when you kind of put all that together, that gives me an ability to look at healthcare, this remarkably complex, nuanced industry from any one of those four perspectives. And so if there's a reason people might find an interest in listening to me about healthcare, it's because I can bring each of those perspectives to bear on this industry, and I think provide insights that maybe someone just more narrowly focused wouldn't see.
Dave has a really great ability to challenge conventional thinking. He has a great ability to draw parallels from outside healthcare.
A deep understanding of American culture, of society, of the trends that are happening globally and in the United States, and he's able to connect the dots.
Part of what we need in healthcare is the ability to have a dialogue on what's the right care at the right place, at the right time, at the right price, that's influenced by what the patients and the customers ultimately need, not by this myriad of cultures and perspectives that come into the marketplace.
The pieces that he writes, the book that he wrote, the speeches that he gives are so insightful. People listen to him and go, oh my gosh, and they come away with these ahas.
He can make it real, so he can talk about policies and changes, but also talk about the economic consequences of what we might do.
They said in most organizations, generating revenue is job one, but honestly, if quality isn't job one, then you're not going to be as good at it as you should be. So the more that we can unleash the power of Americans to make smart healthcare purchasing decisions and support them with the portfolio of companies that can aid in that or actually deliver on that promise, watch out. And that's what makes me hopeful. Is it's at our fingertips. There are many companies doing it today. We just have to figure out how to apply it in more markets more expansively than we're currently doing. Before I get started, I sometimes like to ask knowledgeable audiences like this 3 questions, yes or no, just show of hands. U.S. spends about 18% of its economy on healthcare. The next big country with the next highest percentage is France at 12%. Anybody here think we need to spend more than 18% of our economy on healthcare to provide adequate or even superior healthcare services to everyone in the country? Anybody think we need to spend more than 18%? Okay. Second question, we spend about 80 or 85% of our healthcare dollars on chronic disease. Anybody believe we're winning the war against chronic disease? And remember, you just saw the blue zone, or heard about the blue zone. So based on no hands at all in the air on that, let me ask the third question, which is on a relative basis, how many believe we should shift resources out of acute and specialty care into primary care, health promotion, chronic disease management, and behavioral health? Come on. Right, so what did we learn? That only took about 30 seconds. What did we learn? It's not a funding issue. We have enough money in the system. It's a distribution issue. We're not tackling our most challenging health issue, chronic disease. And finally, we need fairly major restructuring to accomplish the shift that we all agreed with. So it's not really the what to do, it's the how to do it. But before we get into that, let's try to figure out first, how did we get here? So long time ago, probably back at the time when I was doing bond issues with Tom Fahey, or very early in my career, I got asked by this group in New Jersey to come give a talk, and they wanted me specifically to address why is healthcare in America the way it is? It's not like Canada, it's not like Europe, it's not like any of the other developed countries. Why is it so unique? Why is healthcare in America the way it is? And it was 3 months before the speech. I had no idea what I was going to talk about. But at that point in my time, I accepted speaking engagements. And I said, well, I've got 3 months to figure it out. I'll figure it out. You know. Anyway, 2 months, I got nothing. 1 month, I got nothing. And it's a week to go before the speech. And I have no idea what I'm going to say. And I started thinking back about a course I took in college called Religion in America. And it was the first time that I'd heard the phrase American exceptionalism. And I started saying, what are some of the sort of values, quintessential values that make America exceptional? And I started arraying them around the map here. But this idea of American exceptionalism goes all the way back to the very beginning of the country. So John Winthrop, who was the leader of the Puritans, in 1630, just as they were landing in Boston, this is only 10 years after the Pilgrims, 1630, gave a speech where he said they, the Puritans, were a city on the hill with the eyes of the world upon them. Ronald Reagan used that phrase often when he was president. A city on the hill with the eyes of the world upon them. I can tell you, nobody was paying any attention to the Puritans in 1630. They were in a wooded area in New England, surrounded by, almost no people, and yet in their own minds, they believed they were the city on the hill. And it's been that sort of belief in the special purpose of America that settled the continent, won 2 world wars, has been the source of innumerable innovations through the years. So this idea of exceptionalism is right at the heart of us. And the more I thought about it, I said, well, it's got to be influencing healthcare. So you kind of go around the country here and see some of these values, distrust of big government, belief in competitive markets, good in a crisis, not so great on central planning, desire to be the best. Individualism, that's a pretty interesting one. We're one of the few cultures in the world where individual good trumps group good. Very unusual. So when I was on the Christus audit committee, I was part of a strategic planning group. Every 5 years, they went around the country and around the world. And one year, we went up to Toronto. It's probably 10 or 12 years ago. I can't remember exactly. And sort of the prevailing attitude in Canada was, we're a rich country. Everybody deserves health care. If we have to wait a little bit for a routine procedure, that's okay. What we don't want is anybody, feeling they're better and sort of jumping ahead in the line. Well, that attitude would last a nanosecond, as you go south of the border. What do Americans want? Want the best. We want it right now. We aren't really worried about other people too much. We're just going for it. So this idea of individualism, Horatio Alger, it's kind of baked into who we are as a people, and it definitely influences how we run our healthcare system. But sort of with that, the strong charitable tradition and community orientation of which, here's a prime example of. I mean, this company started with nuns coming over and working with their hands, providing health care to those that didn't have it. So this very strong community orientation and individualism, very, very unique. And then kind of rounding out the list, faith in technology, pragmatic and innovative, and belief in miracles. Only a coincidence, by the way, the belief in miracles is coming out of Southern California. But when you put all that together and distill down, you sort of get, okay, best healthcare money can buy, incredible innovation, but on the other side, real gaps in coverage. If somebody doesn't have health insurance, we tend to blame them, the individualism part of this, and a maldistribution of facilities and practitioners. So the answer to the question 20-something years ago and the answer to the question today, why is healthcare the way it is in America, is look in the mirror. Reflects who we are our, as a people, our values, our history, our culture. And that's why if we're going to fix healthcare, we're not going to look like Canada or Europe. It's going to be a uniquely American solution. So the one area, though, where healthcare does not resemble the rest of American society is in its market orientation. And I'll illustrate that with this chart here that takes a couple of graphs from a health affairs article, and it looks at Mass General Hospital. The dark line going down is the mortality rate from 1820 up to 2010. You can see you did not want to be in a hospital in the 1800s. It was very, very, very volatile. But then medicine got better and it became more predictable. The green line is the cost per discharge, and that on an inflation-adjusted basis was almost flat from 1820 up until the mid-1960s. What happened in 1965? Medicare and Medicaid. So President Johnson at the time made two concessions to the AMA in order to get Medicare and Medicaid into law. These are Medicare's two original sins. The first was cost plus reimbursement. So basically, when a provider performed a treatment, they got paid for that treatment according to a formula plus a margin. Cost plus reimbursement. Today it's fee for service, but that's just a natural outgrowth of the original plan. The second feature, a little less known, is written into law, no governmental interference in medical decision-making. No governmental interference in medical decision-making. Therefore, if a doctor can reasonably justify a treatment, Medicare and Medicaid had to pay for it. Well, that's a gap that you can not only drive a truck through, but a whole fleet of truck through. So just logically, if we're going to pay for more care, we're going to get more care. And this was known at the time. There was a public policy, healthcare policy analyst at UCLA named Milton Romer, who at the time observed that in the presence of third-party payment, supply creates its own demand. Let me say that again. It's a little bit of a mouthful, but in the presence of third-party payment, supply creates its own demand. So what we really have in healthcare is supply-driven demand. If you wanted to know, for example, how many cardiac procedures would occur in a given market, logically you'd think you'd look at the composition of the people in the market, the demographics, the age, the lifestyle, and so on, and then come up with an estimate. It's not the answer. The answer is count the number of cardiologists. They literally create their own demand. And there have been innumerable studies across all disciplines to show that number of physicians corresponds to the number of treatments in a market. So literally supply creates its own demand. That's not the way normal markets work. The way normal markets work, there's some intrinsic level of demand, and then supply adjusts and kind of goes up or down a little bit based on price. So we've got artificial economics that really encourage overtreatment. And you can see what's happened, to the cost per discharge. So this is something that people don't think a lot about. But healthcare has a negative effect on standard of living. And let me kind of explain to you why I believe this. So from as far back as you want to go, this chart starts in '92, but you can go as far back as we have statistics. When productivity went up, so did wages, which makes sense, right? If you can use the same or more or less materials and produce the same amount of goods or services, you're creating more wealth, therefore people should have a higher standard of living, more wealth. So that relationship held true until the new millennium, when productivity continued to rise, but median household income, the goldish line there, has been relatively flat on an inflation-adjusted basis. Quite honestly, if you want to know why people are angry in this country right now, that's the reason. They're working as hard as ever, and yet they're seeing no material improvement in their standard of living. Now, lots of reasons for this. 2 major recessions. Probably the biggest reason is the change in the global workforce and shifting of labor overseas at lower cost. But what is not as well known is healthcare's impact. You saw Zeke Emanuel in the video. And Zeke and I have an article coming out in JAMA, the Journal of American Medical Association, in early November. And we're going to introduce this concept of a healthcare affordability index. And it's really simple. The numerator is the cost of a family insurance policy, which is about $18,000. And the denominator is median household income. So today that's about 18%, 18,000 over 57,000. In 1999, which is the first year they started having data for health insurance policies, commercial health insurance policies, that ratio was 14%. So we've seen it more than double in less than 20 years. In fact, the cost of a health insurance policy has been going up at 5.5 times the rate of median household income. So it's literally healthcare ate my raise. And we have some issues in the country when we think about healthcare spending, both in the numerator and the denominator. In the numerator, when people think about what the cost of their health care is, it's their share of the premium, employee share of the premium, plus copays and deductibles, all heavily subsidized. And then in the denominator, we don't think about total compensation, we think about income. But the truth is, when companies are thinking about what they're going to pay people, the cost of benefits, healthcare being perhaps the biggest one, factors into the decision. So this chart, this affordability index, reveals an obvious but hidden truth. Obvious but hidden truth. That is that you can't have a very expensive healthcare system without having an equally expensive health insurance system. And our hope is that, like the Case-Shiller Index, this will catch on, and we'll be able to say things like, healthcare is more affordable in Chicago than it is in New York, based on this very simple formula. We'll also be able to say, it shouldn't be at 31%, it should be at 28%, and start having a reason to push it down. Because quite honestly, if we can figure out as a country how to provide the same or better health care for less money, we will free up enormous resources to pay people more money, like we saw in the previous graph, and also to invest in more productive industries. So I'm bullish generally on the American economy for all kinds of reasons. The innovation, the ability to kind of shift resources around the country pretty easily, which is so difficult to do in other countries. But another reason I'm very bullish is I think we can solve the healthcare issue by getting more effective resource utilization, and we'll get extra energy from that can boost the economy even more. So this is interesting too. This is some work by Elizabeth Bradley when she was at Yale, and she looked at the 12 or 11 leading economies in the world and quantified how much they spent on health care and how much they spent on social care, things like housing subsidies. And you know, this is interesting because it turns out America is an outlier in both ways. Everyone knows we spend more on health care than other countries, but it also turns out we spend much less on social care than other countries. But when you put them together, we're slightly below average. So it goes a long way toward explaining why we spend so much more and yet our results are worse than other countries. We fragment healthcare delivery. We separate healthcare from social care. You know, it's one of the most amazing things is that you know, we separate physical health from behavioral health. You know, if you took your car into the mechanic, right? Mechanic came back and said, you know, your brakes were shot, so I fixed them. By the way, your engine's not so good either. Here's a card and an 800 number. Once you go across town, maybe they'll be able to see you in a couple of weeks. I mean, it just doesn't make any sense. But that's what we do. We separate out physical care from behavioral care. We don't look at the social determinants of health. We have a very fragmented delivery system, and that's a big part of the reason why our healthcare system underperforms relative to other countries. I've got a new phrase I've started to use, and we'll get into it, but is that value follows payment. And you saw earlier that when we pay for activity, we get a lot of activity. Now that we're starting to get new payment models that are more holistic, or maybe look at things like bundles, the system is starting to adapt so it can perform under these new types of payment models. If and when healthcare starts to look like other industries, we'll have the reverse, which is payment will follow value. Companies that create value in healthcare will get the payment. Like in so many things, we got it flipped around in healthcare. So we've been trying to fix healthcare for a long time. So why is this time different? I used to work for Lehman Brothers, you know, may they rest in peace. So why is this time different? And I think what you need to do is look at the payers and the consumers of healthcare and where investment money is going. So from the government's perspective, they are doing everything they can do to start to shift payment toward value. As I said, they're limited in the sense that you can't have governmental interference in medical decision-making, but in terms of the new types of payments where they reward efficiencies, where you create accountable care organizations, the whole MACRA legislation, which is going to fundamentally change the way, or is fundamentally changing the way we pay physicians. And when MACRA kind of works its way into the system, what it means is if you want to pay primary care doctors more, health system, it means you have to do less. So the government has pretty much put a stake in the ground. They're doing everything they can do to figure out how to pay less for health care. Nobody wants to pay more for it. Same is true on the corporate side. Anthem 2 months ago announced unilaterally that they were no longer going to pay hospital-based imaging rates for outpatient services performed in hospitals. In fact, they weren't even going to let the hospitals do the imaging. They were going to send people elsewhere. Well, that happens to be one of the highest profit margin areas inside of hospitals, and it's under attack. It's under attack, again, from companies like Anthem, but it's also under attack from the marketplace. I mean, we're in Chicago now, and there's a company out of Wisconsin called Smart Choice MRI. They're running ads on the billboards of the buses, or sides of the buses and in billboards. They say things like, you know, an MRI shouldn't cost an arm and a leg, and the cure for the $2,600 MRI. So basically, they're saying they will provide MRIs for $600 or less at very convenient neighborhood centers. And then people say, well, yeah, what about the quality? Well, they get second reads from the Cleveland Clinic. So what's starting to happen in the marketplace here is imaging is collapsing around that $600 price point, which we're going to see all over the place. So when a commodity item in healthcare, when the pricing becomes transparent, when the outcomes are measurable, we will start to see the pricing coalesce around those lower price points. So pressure from government, pressure from corporations. Corporations like GE and Walmart and Boeing are also becoming much more demanding purchasers of healthcare services. It's been one of my surprises as I've been in the industry that corporations that really overpay, pay a premium for healthcare services, haven't demanded more value. That's starting to change. Consumers, you know, the American consumers, when unleashed, are value-seeking machines. Everybody bemoaned the loss of the mom-and-pop hardware stores in the 70s and 80s. But when it came time to shop, they went to Walmart. And why did they go to Walmart? Because more choice, lower prices, greater convenience. You know, today Amazon is Walmarting Walmart in many respects, right? Because through the online shopping, same reasons: greater choice, greater convenience, very competitive prices. So, you know, but when it comes to buying healthcare, consumers are often at a loss. They don't know what the price is. There are lots of barriers. But what we're starting to see is that in certain items, particularly when there are high deductible plans, consumers are becoming more discerning. So when it's their own money on the line, when it's your own money on the line, you're going to be a better shopper. But we're also starting to see the emergence of intermediary companies that help consumers make better, more cost-effective decisions. I'll give you an example. There's a company called Carum, C-A-R-R-U-M, out of San Francisco, that works with self-insured employers to find bundled prices for surgeries. So there was a deputy sheriff in Santa Barbara who needed a knee replacement. The county manager of Santa Barbara said, you know, we have 2 hospitals in town. One's really expensive and the other's exorbitant. Yeah, really expensive and exorbitant. So this company, Carum, arranged for the sheriff's deputy and her husband to go down to Scripps in La Jolla, Scripps nationally recognized system. They paid for the trip. She and her husband stayed in a spa-like setting for 4 or 5 days. She got to pick her doctor, had the surgery, did the rehab, got $1,000 in spending money, and oh, by the way, saved the county $30,000. So those, you know, the emergence, and so everybody's happy. Everybody's happy except the hospitals in Santa Barbara. So I think what we're going to see are more and more companies like that kind of come in an intermediary role and exploit areas where there are these big pricing variations. And just like with the Smart Choice MRI, they'll kind of push that back. And then the last point is, where's the smart money going? And we have unprecedented amounts of private equity and venture capital funding flowing in not only into healthcare services, but into provider-based services. And I just mentioned 2 companies, right? Smart Choice MRI, venture funded. Carum Health, venture funded. So the smart money is seeing enormous opportunity in the delivery side of healthcare, and it's going to pick its spots and attack and root out the inefficiency and bring more value overall to society. So that's good for American society if we can bring prices down, bring value up, but it's going to be tough on the marketplace, on the healthcare marketplace and providers. So I was trying to figure out what was going on, and this is a couple of years ago when I was writing the book, and I came up with this very simple chart. And on the x-axis is care duration, episodic, one time versus ongoing. And then on the y-axis is care uncertainty, low to high. And so if you're in that lower left quadrant, where you know you're going to have a good outcome, so you're not worried about the outcome. It's like an MRI. I mean, nobody ever has a bad outcome with an MRI. the perception and the reality of quality shifts from am I going to have a good outcome to convenience, customer experience, and price. Convenience, customer experience, and price. So that's really a retail item. High volume, low margin services. And guess what? Probably 80% of what happens in healthcare on the delivery side is in that lower left bucket. So if you go up to the upper left, these would be where you have an uncertain outcome, but it's episodic, so something like a heart transplant. What you're going to see there, I believe, are the emergence of real national centers that do high volumes, so focus factories, if to use a term that some people use. Right now in Chicago, we have 6 hospitals that do heart transplants. None do more than 25 in a year. It's just crazy. Both quality will go up and costs will go down if we start to do more volume for tough cases in centralized locations. And I think the focus factories, especially hospitals that are able to demonstrate better outcomes and lower costs in a much more tangible way will be the ones that get the more volume over time. And here's kind of a scary thing, is all of this is coming down. So knee replacements, hip replacements, which used to be the epitome of specialty care, if they haven't already, are very close to coming into commodity care. People are bundling or bidding for them on a purchase service basis. So you go to the upper right, complex care. These are the really tough cases, right? The solution shop cases, comorbidities, sickest of the sick. You need really expert practitioners, a lot of them. They have to communicate. This is going to be expensive. This isn't something you're going to be able to bid out or pay for in a bundle. You know, this is trial and error, the really tough cases, the kind of cases that the Mayo Clinic handles. The question is, how many places like this do we really need in the country? And we certainly have many more organizations aspiring to be centers of complex care than we need. So there'll be rationalization in that space. And then you come down to the lower right, the non-acute chronic care. And if you don't think CVS and Walmart are going to be in this in a big way in 10 years, it's our biggest need. They're close to the customers. I mean, Walmart is starting to set up clinics. They at some point 3-4 years ago announced they wanted to be the largest primary care provider in the country and then backed off from that. But they're still pursuing that goal. And you think about it, if you go to the clinic at Walmart and see the nutritionist who's just given you, the book, The Blue Zones, and saying, you really need to change your diet. Here's your menu for the next 30 days. Oh, by the way, go to aisle 2. They'll fill it up for you. And you need some exercise equipment, so go to aisle 6 and get that there. So they are much better positioned in many respects to meet with the daily ongoing health needs of people with chronic conditions than the current delivery system. And the delivery system itself is morphing because we're starting to see companies like Oak Street Health that are investing in expanded primary care and really getting to know members. So that's changing too. And the problem with hospitals and health systems is they tend to want to be all things to all patients. But each of these are very different business models, different supply chain, different types of patients, different types of expertise needed. And when you try to be all things to all patients, invariably you're not going to be as good at all the individual components as somebody who's only focused on that area will be. So differentiation, targeted solutions, that again is, I think, good for society, but bad for the current way that we structure and operate our healthcare system. So who are the disruptors going to be? I love this quote from Bill Gates. He said it probably in the late 90s. We always overestimate the change that will occur in the next 2 years and underestimate the change that will occur in the next 10. So don't let yourself be lulled into inaction. So if you generally kind of believe the trends as I'm outlining them, which is this more of a bottom-up, market-driven reform, then if you're in a position of having lived off fee-for-service forever, you're probably saying, well, maybe it's not going to be here forever. But there's still a fairly high level of complacency in the system. Fee-for-service, when you actually look at it, is still about 85% of the payment. And we just shouldn't be lulled into inaction, because under the scenes, there are all kinds of forces that are rearranging and targeting different aspects of the system and going after them hard. So I already talked about focus factories. I talked a little bit about enhanced primary care companies. I'll tell you about another one. IORA, you saw Rushika Fernanderpool, who in the video. Rushika's a pretty good friend of mine. He started this company, IORA, and his idea was healthcare needed the equivalent of a Southwest Airlines. He's an engineer and doctor by training, and he thought originally, if you fix the systems, you could fix healthcare. But he then decided, no, it was just broken. We needed a fundamentally different way of doing it. And so he chartered IORA, which is an enhanced primary care company. So if you become a member of IORA, it's per member per month. They own your healthcare risk, and they have unlimited primary care visits. Every member gets a primary care physician, a nurse practitioner, and a health coach, free yoga classes, free lifestyle improvement classes. They want you to be coming into the center as much as possible. If you do get sick, you'll get care navigation. There's 24/7 access to the clinic through Skype, email, all the other types of digital communication. And they're selective about where they go for the specialty care. So the belief is, if you really get to know your members, they'll trust you to work with them to improve their health. They'll be more honest with you about what they're really doing, not what they say they're doing, because guess what? People lie when they're actually telling you what they do about their health. How many times a week do you exercise? 3 or 4? Oh, yeah. And I think that's right. I think that if you have that kind of trust at the primary care level, there'll be less need for acute interventions. We'll catch things earlier. People will be healthier. It's actually an old-fashioned model for how we used to provide health care. We got away from it. But there's a whole host of these new types of enhanced primary care companies that are coming to the market. Retail clinics we talked about. And then the last one is asset-light providers. We have one right here in Illinois, the DuPage Medical Group. People know them. Very largest multi-specialty group in Illinois. Every health system has wanted to acquire them because they're such a source of volume. And they've remained staunchly independent. And then in January of 2016, they raised $20 million, or $250 million from debt and private equity to expand their model. And their model has things like ambulatory centers that run 6 days a week, 2 shifts a day. So they do 20,000 procedures a year in an ambulatory center out west. A typical ambulatory center in the country does 7,500. They have a breakout center for frail elderly. So when they present in an emergency room, they don't, unless it's absolutely critical, they don't admit them until someone from the breakout center comes over and sees the patient. And 9 out of 10 times, it's something that doesn't require emergency care, dehydration or something like that. So they are what I call an asset-light company. They have doctors, they've got internet capabilities, they've got nice organization. What they don't have is a lot of high-cost facilities to carry. And guess what? 2 months ago, they just got $1.5 billion from private equity in California to take their model nationwide. So just think about all of these different types of companies attacking the traditional healthcare hospital business. It's coming from all sides, and it's kind of ruthlessly looking for inefficiency and trying to exploit it. So what's a hospital to do? Einstein had this great quote where he said, if you're playing a new game, you got to learn the new game's rules and play it better than anybody else. And so I came up with 5 value rules, and a little bit of a turn on the phrase that, if you follow these value rules, you will also rule your marketplace. But the first one is quality is job one. There are a lot of people here as old as I am remember the Ford commercials from the early 80s. You know, we used to build really crappy cars in this country. We had this concept called planned obsolescence. The big three held all the market share. And the idea was, you know, they wanted people to buy new cars on a regular basis, so they built crappy cars and they controlled the market. And then Japan came into the marketplace and fundamentally challenged the U.S. automaking industry by building very affordable, very reliable cars. And Ford, to its credit, said, you know what, we got to get back to basics. Quality is job one. They ran these commercials with these crusty engineers in white lab coats, you know, putting cushions around ball bearings. And anyway, Ford won a number of quality awards. It's probably the reason they were the only automaker in the country that didn't require assistance during the financial crisis. But they went back to basics and they made quality job one. A sad truth about American healthcare is quality is not the first priority in most organizations. It's optimizing revenue. I spoke at the Becker's conference here in town, IT and Revenue Cycle conference 3-4 weeks ago. There must have been at least 100 revenue cycle companies that were exhibiting. Job one in most hospitals is optimizing revenue. We spent tens of billions of dollars on electronic medical records through the HITECH Act. First rule of performance improvement is fix a system before automating it. It's not what we did. We took a broken system, focused primarily on billing, and have spent tens of billions of dollars to automate it. And the result is doctors are now spending 2 hours in administrative time for every hour with patients. Technology is supposed to make life easier, not harder. Our problem with healthcare is, since quality isn't job one, optimizing revenue is, and quality is bolted on to the electronic medical records, we're just making it far more difficult to run organizations, and we should be running them to generate the best outcomes at the lowest price. So rule number one, quality is job one. Care episodes, not treatment codes. I gave you the story about the sheriff from, deputy sheriff from Santa Barbara. That was one price for an entire care episode. It's the way we should do it. We shouldn't be billing out for every little piece. I can't tell you how a microwave works, you know, the electronics of it, but I do know if I put in some microwave popcorn and push a button, you know, a minute and a half later, I've got popcorn. That's, you know, I want to know, when I buy a microwave, I want to know how much it costs and what it can do. And we ought to be looking at care that same way. Now, there are some cases, obviously, where you can't bundle it together, but again, those are a minority of cases. The vast majority of things are relatively predictable and able to bundle together. So thinking about care episodes, not treatment codes. Third one, price matters. And I gave you the example of the deputy sheriff. So if you can get a knee replacement for half the cost and get spot treatments and $1,000 of spending money, maybe prices do matter. Smart choice MRI. So as we get more transparency around outcomes and price will start to matter in the same way it does in every other element of our economic lives. Data is as data does. I just spent a little bit of time talking about the electronic medical records. And our problem is we often don't get the little data right, and then we apply a big data solution. So again, first rule of performance improvement is fix the system and then automate it. Figure out the right kinds of data you need to make decision making, and then automate it, make it bigger. Now, there's enormous promise with all kinds of data systems, predictive analytics, machine learning, and so on. But all of that has to be focused on how do we deliver the best outcome. And ultimately, we need to figure out how to have machines and human beings work together. A friend of mine calls it DAMM, D-A-M-M, decisions almost made by machines. So I'll give you an example. There's a company in Minneapolis, Hypnosis, that has a virtual urgent care clinic. So you go online and you punch in your information, and it's got machine-based algorithms that are looking at that, and they're starting to channel the diagnosis so that when the caregiver comes into the equation, you're already 90% of the way to a diagnosis and a recommendation for treatment. Now, one of the things they discovered is that when you go to urgent care, and urgent care usually costs about $40, and if what happens is you just randomly get a practitioner who listens to the symptoms or types back and forth. You have as much variation in treatment and outcomes as you would have if you went to any kind of clinic. But hypnosis, because it does this channeling based on the information as it gets it, has much less variation, much lower or much better consistent outcomes, and it only costs $25 instead of $40. So that's an example of how data and technology and machines can work, but we have to get the little data right, and we have to have the right processes. We can't start from the top and just assume we're going to spend all this money on systems and we're going to get the outcomes we want. And then finally, it's the customer stupid. We haven't figured out exactly how to unleash the consumer, but we're kind of getting at it in a lot of different ways, a lot of the new business models. Medicare Advantage, which has gone from 5 million people 10 years ago to 17 million, so it's more than tripled. People are choosing that over traditional Medicare because they're marketed to, they get more services. It's going to be the customer, just like it is in every other industry. Deming has this great quote that businesses exist to serve customers. It's actually pretty obvious. You can't have a business without customers. Somebody has to actually want to pay you for what you're doing. But healthcare is a funny business because it's the only one I know of that the principals execute transactions without customers. So you go to the doctor tells you what to do, you do it, and then somebody else pays for it. It severs the buyer-seller relationship. And I think we're starting to put that back together in healthcare, and it'll be a good thing when we do. We talked a little bit about the economics. So this is my old math, new math. So the old healthcare math is revenues are flexible. That's why there's so much money invested in revenue cycle. You can always code a little bit better. You can always get a little bit more money. Expenses aren't that important because they're built into the reimbursement codes. And then the difference is the margin. And the managerial focus is on getting paid. How do I get paid? That's something I hear all over the country. The new math is revenues are inelastic, fancy way of saying they're largely fixed. So if you're going to get an MRI, it's going to be $600. And so the question is, can you manage the expense profile so that you can make a profit on that? So managing expenses is really, really important. The difference is profit or loss. And the managerial focus then is on how do I create value. So that requires continuous performance improvement, cost accounting. I mean, actually, everything you really need to know about hospitals in this country is they have robust revenue cycle capabilities and, at best, rudimentary cost accounting capabilities. Again, that is all starting to change. And as I said, value follows payment. But ultimately, payment will follow value as we get to more and more of these per member per month bundled payment type arrangements. So I've got another article coming out this fall, co-written with Amy Compton-Phillips, who's the Chief Clinical Officer at Providence Health and Services. I'm sure many of you know them. In fact, one of your hospitals is affiliated with Providence, right? So Amy and I are on a board of a technology company together, and earlier this spring we were talking about healthcare, and she said, you know what, I think in the future it's going to be a platform. We're going to think about healthcare companies as platforms, not buildings. And I said, you know what, I agree with you. And so we spent a little time talking out and came up with this article. And here's a chart that explains it. So all companies have inputs and outputs. Inputs are things like labor, technology, facilities, data. And the outputs in healthcare are outcomes, care maintenance, disease prevention, health promotion. And then inside the box, inside the company, you figure out what is it you're really good at and you want to own. What is it that's really important that you're not so good at that you want to partner with? And what can you just buy or outsource? And the mix of those activities determine how effective you are at getting your outcomes. And we want to measure as the best outcomes at the lowest cost. And historically, the strategy for most hospitals and health systems has been to own and control everything. That's the way we optimized revenue. But when we shift to a world where we got to deliver the best outcome at the lowest cost, we become agnostic with regard, should become agnostic with regard to whether we own it or partner or outsource it. It's just whatever the right mix of attributes is that gets you that great outcome at the lowest price, that's what you should do. And what's going to differentiate companies in the marketplace are brand, price, and customer experience. I heard a lecture, or actually just a Q&A session the other day from the CEO of a very high-end hotel resort company, and he described the company business philosophy as being asset light, so they're management contracts, they don't own any buildings, and brand heavy. Asset light and brand heavy. So everything they do inside the building is to reinforce the brand, create a relationship with the customer, build loyalty, and so on. So the last bullet point here, John Powers, is a way to drive this point home. So John Powers was one of the first marketing leaders in the country. He did the early marketing for the department store Wanamaker's in Philadelphia. Some of you may remember, it's Macy's now, but for a long time, Wanamaker's was one of the great department stores in the US. It was the first one that had price tags on all the items they sold. Their belief was everybody's the same in the eyes of God, therefore everyone should pay the same for items. And John Powers did the marketing for Mr. Wanamaker. Drove him crazy a little bit. He would have ads like ties, 25 cents. Not that well made, but a great value. And Wanamaker hated that, but they would fly off the shelves because people trusted what they were saying. So he had 3 commandments, what he called them when it came to marketing. And the first was be interesting, right? If you're going to be in the marketing business and you're boring, it doesn't matter what you're saying. Nobody will pay any attention. So you had to be interesting. Second was to speak the truth. And the third was to live the truth. And if you couldn't live the truth, then change what you were doing so you could. And unfortunately in healthcare, we've got a lot of hypocrisy. We have a lot of places that say they put patients first, but they really don't. And again, I think our human brains are sort of set up to root out hypocrisy and figure out social standing and so on. And I think the industry runs a real danger every time it gets exposed for doing something for economic reasons and not for the reasons it's saying it's doing. How many saw the 60 Minutes program last Sunday about the pharmaceutical industry? And yeah, so a lot of you. I mean, pretty incredible. The pharmaceutical industry, the Drug Enforcement Agency was trying to slow down the spread of opioids, which are devastating the country. And in 2006, they shifted from focusing on bad doctors and bad pharmacies that were kind of over-prescribing opioids to going upstream to the distribution companies. And these are big companies. This is McKesson, Cardinal, AmerisourceBergen, big companies. And they had an affirmative right under the 1970 legislation to report suspicious drug orders. So the DEA started investigating distribution companies and holding them accountable when there were suspicious orders that they weren't alerting the DEA to, and then started bringing action against these companies. Hundreds of millions of dollars of fines against these companies and others, distribution companies. Well, the pharma industry didn't like it, and they spent the better part of 3 or 4 years and over $100 million lobbying, and they basically gutted the Drug Enforcement Agency's ability to stop suspicious drug sales. And it just all blew up with this release of an investigative report. Well, if you were to go, I'm sure if you go to any of the websites of any of those distribution companies, they're going to talk about all the wonderful things they're doing and why they're doing them. But here, they were clearly pushing opioids on communities because they were making money. And rather than change what they were doing, they changed the law. Not only tried to control public policy, but actually tried to control enforcement and got away with it, but for the fact there was a whistleblower and this investigative report. And the congressman from Pennsylvania that sponsored the legislation was Trump's pick to be the drug czar, and he removed his name from consideration on Monday. But that's what I'm talking about. We've got a lot of that in healthcare. We got way too much of it in healthcare. We need to live the truth and speak the truth. And so if you say you're going to put patients first, well, you better put patients first. I mentioned pharmaceuticals, very timely, but this is the one area of the marketplace that I'm most worried about. we have enough hospitals, we have enough specialists, we have enough rehab centers that if we get the incentives right and set it up, I think the marketplace will sort itself out. We'll get more efficient resource utilization. It's not as true in the pharmaceutical world. It's 14% of healthcare spending and growing. Not that long ago, 5 years ago, it was 10%. This 1173, so 11% of the drugs that pharmaceutical companies make are branded drugs, so they carry a label. The other 89% are generic. But that 11% constitutes 73% of their revenues. So for most drugs, they're readily available, they're fairly priced. Walmart does $4 generics and so on. But all the games occur in these branded drugs. And right now, the pharma companies, in many respects, get more out of lobbying than they do out of competing in the marketplace. So they got over 1,000 lobbyists. That's more than 2 per member of Congress. And they're engaged in things like I just talked about. But when you go through the patent process, there are all kinds of ways to extend patent life, to change dosages, to create little monopolies. And I'm a markets person. I mean, the title of my book was Market versus Medicine. But the public policy part of me says, you know, when you got market failure, you need balanced regulation. You need to get to that Goldilocks spot where not too much, not too little. So we don't want to stifle innovation. We want to reward innovation, but we don't want to create these monopsonistic situations where companies can charge anything they want once they get licensed to do it. So Sovaldi is a really interesting challenge because Sovaldi cured hepatitis C. This wasn't a drug that was just marginally improved. It actually cured a disease. But they came out at such a high price point, Gilead did, that if we gave Sovaldi to everyone in the country that needed it, we would spend more on that one drug than we would on all other pharmaceuticals combined. Now, the marketplace is working a little bit. We've seen some other Hep C drugs come in, and the prices come down. But we do have to sort of think about when we create these oligopoly-like situations, maybe pricing should be a part of that as well. It's a difficult road, but absent that, this 14% is just going to keep going up, and we don't have brakes on the system to stop it. So here's the thing I really worry about is a crappy Alzheimer's drug. They're spending billions of dollars on Alzheimer's. None of it works. At some point, somebody's going to produce a drug that's going to be just a little bit better, cognitive function, a little bit better, and they're going to charge $500,000, $600,000 a year for this drug. And we've got a societal question we need to work out, which is, you know, for a crappy Alzheimer's drug, how, you know, is that worth it? But the way we're set up now is that's what we have to look forward to. We've got these very expensive cancer drugs that are in the pipeline, $150,000, $200,000, $250,000, $300,000 a year. They address very small numbers of cancer, but are enormously expensive costs on the system. So how do we as a society kind of get that together? So I kind of went through the bullets without talking about the graph. Well, this is the EpiPen fiasco from the summer of 2016. And what's kind of interesting here is, you know, the retail price, the $608. Mylan, the manufacturer, a guy, I can't read it, but it's like 284 or something like that. All this other stuff went into the middle, and it's opaque. We don't know how much the distributors take. We don't know how much the pharmacy benefit managers take, and so on. And Representative Lloyd Doggett of Texas said, we've moved from the point where there is no problem to it's not my fault. It begins to focus attention on what of my constituents already know is the problem, which is price gouging. So as the pharma companies are taking advantage of the regulatory network, you know, we get episodes like EpiPen, which $608 for a 2 EpiPen set. But there's good news. You know, I think Amazon is looking at that big spread in the middle, and they're salivating. they're saying, oh my goodness, look at these intermediaries and how much money they're making. We can go and attack that. And they've announced they're going into the pharmacy business. And what are they going to do? It's not hard to predict. They're going to focus on the customer. They're going to create value. They're going to take advantage of their distribution system. They're going to cut deals with manufacturers. They're going to do everything they can do to get rid of the middle, just like they did in books. So there'll be a real retail squeeze. And so what's a health system to do? I think the health systems and the pharmacy manufacturers are potentially natural partners, but they have to work together to actually create real value for patients. So getting the right drugs at the right price, and then making sure people take them in the right ways. So this is my last slide. So here's the book. I'm a shameless promoter of my book. It's got 4 sections: assess, align, adapt, and advance. Until you assess a problem, you really can't begin to solve it. So hopefully, we've given you some sense of both what the problem is and how I think the marketplace is organizing itself to attack it. The align from the health system perspective is, how do we get better at what we're supposed to do? How do we deliver more efficient care, more compassionate care, better outcomes, fewer errors, greater convenience, sustaining innovation. Adapt is the disruptive component. When we flip the pricing, so it's per member per month like it is in a health plan where you own the care risk, then suddenly a hospital admission is a last resort, not a first resort. There's all kinds of incentives to do earlier diagnosis, better chronic disease management, and so on. So we're asking a lot of the industry because we're basically saying, you're not that good at what you're supposed to be doing. We got to get a whole lot better on delivering right care, right time, right place, right price. And oh, by the way, while you're doing that, why don't we figure out how to flip the incentives all around so that everything you've been used to doing for the last 50 years, you have to do differently. So it's a big challenge. But here's the scary thing, and this was the last section of the book, the advance piece, is we could fix healthcare, right time, right place, right price. But if we do nothing about the lifestyle conditions that we're promoting or that society is promoting, our future is going to be ever more chronic disease, more inequality, lower productivity, less happiness. I mean, that's not a future that anybody wants. And I'm delighted that the speaker that preceded me, and it's good he spoke right before lunch, is Eric Buettner. His dad, Dan Buettner, did the Blue Zones, and you know all about that. But at the last chapter of my book, I have 7 wellness heroes, and Dan Buettner was one of them because I thought he clarifies in that work that we all have a choice, that we can live, absent some, bad luck, but we can live a long, healthy lifespan. It's in our power to do it, but it requires lifestyle change. So a question for American society is, how do we reverse the trends of the last 30 or 40 years and make it easier for regular people to make smarter lifestyle choices? Now, I believe that, again, the marketplace will be a big part of this. The title of this slide is Demand-Driven Change, Superhero Results. McDonald's is experimenting with kale salads, not because it doesn't want to sell more burgers, it's because the marketplace is changing. So part of what we need to do is get people wanting and buying different things that promote a healthy lifestyle, don't promote an unhealthy lifestyle. I'll give you an example of what I mean. So when did the Blackhawks last win the Stanley Cup? 2014, I think it was. And I was watching a lot of hockey. And there'd be these long commercial breaks between periods. And there were these 2 commercials that were running back to back. So Hardee's had a new thick burger, and they were advertising it. It was this massive thing. It was half-a-pound hamburger with a hot dog on top of it, shrouded in cheese with kettle chips, And they had that, and they had a supermodel in a bikini in the back of a pickup truck on an aircraft carrier in New York Harbor with fireworks going off. So that was one commercial. And then the next commercial was John Hancock, the insurance company. It showed this very trim woman running up the stairs in an office building, counting the steps on her Fitbit. And John Hancock was saying, you know, if you share your fitness information with me, we'll give you lower cost life insurance. Actually, it was a little bit of an illumination to me. I said, well, yeah, it makes sense. You know, if you're a life insurance company, you don't want people to die. You want them to live a long time. So it's in their interest to promote long health. So I think part of the question for us as a country, are we going to be more Hardys or more John Hancock? I mean, it's in our power to choose, and we have to figure out how to make that happen, because we don't want the future that we're currently on. So as a society, we have to figure this out. So demand-driven change, superhero results, and I'm happy to take some questions. So thank you very much. Got to be some questions, right? Yeah.
Hey, Dave, could you take a minute and talk about how what's happening today in terms of per member per month payments and how that's really different than what happened in the 1980s with the HMOs? Because that was conceptually
Right.
the same principles,
Yeah.
but it seems it's very different.
Yeah. Dennis, great observation. What happened in the 80s and the 90s with the explosion of the HMOs was we did shift to what many people thought was a more logical way to pay for health care. We'll pay you a certain amount per month, and then you have the care responsibilities. Now, if an organization is honest and actually is trying to promote health, they will take that seriously, and all the incentives align just the way I talked about with IORA. But another way to look at it is I get so much per member per month. I can make a lot of money if I figure out how not to provide care that people need. And that's what we were doing. We were actually paying gatekeepers to provide or to stop care that was probably necessary. I remember going to see the movie As Good as It Gets with Helen Hunt and Jack Nicholson. And it was down here at the Century Landmark in Lakeview, near my house. And in that, Helen Hunt has a son that's got asthma, and in the middle of it, she goes on this profanity-laden rant against the HMOs because they're denying her coverage. And honestly, people in the movie theater started cheering. They were clapping after. Everybody was angry at the HMOs. And I said at the time, I said, you know, it's over. You know, that experiment is over. So what's different now? First off, you know, example on Medicare Advantage, which when you get through it is really a per member per month program. They rate the plans 1 to 5 stars, and you actually can't make any money for quality. Rate 1 to 5 stars on quality. You actually can't make any money in Medicare Advantage unless you're a 4 or 5 star plan. So I think today we have a much better understanding of quality, and we hold the plans accessible that go into that per member per month, and we're only going to get better at that. My company has a joint venture with another small company in the Twin Cities that does big data analytics. These guys used to work for Target. Anybody ever hear the story about the father who went into Target and complained that Target was sending his teenage daughter advertisements or coupons for diapers and cribs and so on, and he was incensed and went into the store and said, you know, are you trying to encourage my daughter to have sex? This is terrible. You know, really chastised the store managers. Manager apologized, said he'd look into it. So 3 days later, he was calling up to apologize some more and explain what had happened. And what had happened was Target had an algorithm that looked at purchasing habits, and they could say with 90+ certainty if you had this basket of things that you were buying, you were pregnant. And guess what? The father came on the phone, the manager started to apologize and said, and the father said, no, I'm the one who had to apologize. Turns out I didn't know everything that was going on in my house, and his daughter was pregnant. So they're the big data scientists that figured out how to look at all this purchasing data and do that. And they decided they wanted to use this skill not to sell more toothpaste, but to actually help make better healthcare decisions. And it turns out, first off, the amount of information that's available all of us in the marketplace is just beyond scary. So they have data on 250 million people, and if they can get your 9-digit zip code and your address, they know a lot about the system knows a lot about you. But what's really interesting is we've got a problem with predictive analytics if we only look at clinical data. You would think the people that are sick this year are going to be the people that are sick next year, but that's not the way it works. There's a phrase called reversion to the mean. It's the people that were sick get better, and then this new group gets sick. And it turns out that purchasing data is a lot more predictive, accurate than clinical data. When you put them together, they're much more accurate. So I'll give you an example. So you take two middle-aged Caucasian men, same zip code, both managers, same income, both divorced, and clinically, little high blood pressure, overweight, and so on. They clinically and demographically look identical, but one of the individuals votes all the time, has a dog, reasonably involved in his community, which you can tell from his purchases. The other one has just moved from another community, clearly has no pets, rarely votes, isolated. So it's very easy to conclude that this more isolated person, social determinant of health, is much more at risk for an acute episode than the other person. So if you're now a health plan and you have responsibility for managing the care of this group, this kind of information can be really valuable. So I think we're monitoring quality. We've got tools that properly applied, and if we get the incentives right, we can just do a better job of taking care of communities. So I think that's what's different, and it's night and day different. I'm all yours. Come on, got to have some more questions. Yeah.
You mentioned that pharmaceuticals make up 14% of the healthcare expense. Seems kind of low to me. How about the other 86% approximately? Where is that all?
Hospitals are 40, doctors are 30, post-acute is the rest. Roughly. And again, pharma's coming up and the others are coming down. What's that? Well, this is the spending on healthcare. So the insurance companies are payers, not spenders.
When they pay.
Yeah.
Then they're to make money. That's the bottom line.
Yeah, they are.
And their idea is spending less for the healthcare.
Yeah, I'd take you back to my affordability. I mean, everybody likes to beat up insurance companies, and I do it as well, because the equivalent of fee-for-service in the insurance world is these contracts, these ASO contracts, where they get paid to manage claim, third-party administrator, and they take 15% off the top to, manage claims, which is probably a 2 or 3% function, really, and tend to get paid on a percent of claims administered, so they actually benefit from more care, not less care. So, I'm with you there, but the real problem with insurance, and it's the exchanges are bringing this out, is our healthcare costs a lot of money, so therefore our insurance costs a lot of money. And we can argue about how much the insurance companies take off the top, and I think they take off too much. You heard my talk about the story about pharma and the DEA. Insurance, pharma is by far the biggest buyer of lobbyists in the country, but insurance is right down there. And it kind of brings up a point that I think is important. People mix up what it means to be pro-market and pro-business. They kind of think the two go together. We all should want to be pro-market. We want level playing fields. We want the best companies to win and so on. Pro-business is a little more complicated. It's like the pharma companies. Everybody loves being pro-market, but then when you get market share, you're actually trying to keep other people from coming in and taking away from you. It's hard to be competitive. So we need to be pro-market, and we should be pro-businesses when businesses are pro-market, like what Amazon is doing in pharmacy. But we need to criticize business when it steps in and does things like, the pharma industry did with the Drug Enforcement Agency. Yeah?
We were all wondering why population health hasn't taken off as yet. Understanding that that's probably going to be the answer to quite a bit. And
Yeah.
of course, it's not taking off because it's follow the incentive, follow the money trail. If you pay for it, it'll be
Right.
It'll happen. So why aren't we paying for it? Why isn't the government stepping in?
The government.
Right. Well.
Yeah.
Incentive payment, and you gave quite a few examples.
Yeah.
Where it's that full risk share, and you can.
Yeah.
And if you set it up, if you have your
Yeah.
It is a form of population health.
Yeah, no, you're absolutely right. We need to do population, and we need to get better balance between social care and health. And I have this phrase I called AHA care, AHA care. Let me see if I can remember what it is. It's accountable, holistic, and affordable healthcare services that are, what's the C? Anyway, I'll come back to, coordinated, accessible, reliable, and evidence-based. That's what we should be having, thinking about the whole picture. I'm of the opinion, I've got a piece coming out, it's called Honey and Vinegar. My grandmother used to say that you catch more flies with honey than vinegar. And people have heard that before, right? And I think what the government tends to do on pricing is more vinegar. It's like what Anthem did, where they said, okay, we're just not going to pay for outpatient imaging, or hospital-based prices for outpatient imaging in hospitals. And it creates friction, creates heat, people fight it. But the other way to do it is like this Carum Health, which is the honey side, which is they made everybody happy. The deputy sheriff got a new knee and a great vacation. This county saved a bunch of money. So I think we need to get to a place where we have more honey and less vinegar. And when I think about the federal government, CMS, Medicare Advantage is much more honey, and value-based payment has been pretty much a failure. We've been at it for 7, 8 years. Savings to the government are about 1%. So $100 on a $10,000 average Medicare participant member. You can save that by doing one less test. And again, the value-based payment is top-down. It's really complicated. It's got a lot of regulatory stuff that comes with it. It creates heat and not light. So I'd like to see us do more Medicare Advantage, more Medicaid care management, more per member per month, more bundles. And I think we'll create systems that the marketplace can respond to. We'll get more honey and less vinegar. But part of the reason is we're still 85% fee for service. And until we fundamentally change that, we're going to live like we are living. That it? Well, good. Well, thanks. This has been fun. I really appreciate it. And I know this has been a remarkable time for this organization. You made some big decisions. So you can see how turbulent the environment is for healthcare and hospitals. And so I think your future is great with Rush, at least here in Chicago. So thanks again.